Today I'm joined by Dr. Megan Steele, a doctor of physical therapy and PhD candidate at Azusa Pacific University, where she's researching the connection between our visceral and musculoskeletal systems and how that impacts chronic pain. She also teaches in the DPT program at Mount St. Mary's University, which means she's actively shaping how the next generation of physical therapists think about pain. This conversation really gets into the science of chronic pain. We talk about why biology and psychology can't be separated, what's really happening when pain becomes chronic, and why just move differently is the physical therapy equivalent of just think positively. If you've ever felt like your pain wasn't taken seriously or like you were being handed oversimplified answers, then this episode is for you. The Chronic Illness Therapist podcast is meant to be a place where people with chronic illnesses can come to feel heard, seen, and safe while listening to mental health therapists and other medical professionals talk about the realities of treating difficult conditions. This might be a new concept for you, one in which you never have to worry about someone inferring that it's all in your head. We dive deep into the human side of treating complex medical conditions and help you find professionals that leave you feeling hopeful for the future. I hope you love what you learn here, and please consider leaving a review or sharing this podcast with someone you love. This podcast is meant for educational purposes only. For specific questions related to your unique circumstances, please contact a licensed medical professional in your state of residence. Well, thank you so much for being here. In fact,
so
the reason I was just, we were talking offline before, but the reason why I wanted to have you on was because I felt like you, from the Instagram content that you've been doing, you do understand the difference between, like, you talk about pain neuroscience, but you're not chalking it all up to it being in someone's head. Like, you really balance that approach between, here's what's happening in the body, and here's how the fear is lighting up around that. And here's what you maybe can do and maybe still can't do. And that's not because you're scared. It's because you have a thing happening in your body. So that is, why I invited you on. I'm really excited to talk about our work, how our work collides. And I'd love to start with just having you kind of talk about maybe your practice and what you have going on these days.
Sure. Yeah. Well, every day is different, which I think keeps me, I like to say, out of trouble. And so, like a day like today, I'm in the clinic and then doing things like this, podcasts. And Monday, I was teaching at Mount St. Mary's. This semester, I'm teaching an orthopedic pathology course to the first years. And then I don't see them again until the third year when I teach them a pain science course, which is really kind of my bread and butter, my favorite thing to talk about. And then on Thursday afternoons, I go to Azusa because I am in the data collection portion of my PhD at the moment. And so I'm there collecting data on participants for my dissertation study.
That's awesome. Tell me, what is your dissertation on right now?
So the umbrella program that I'm in is rehabilitation and movement science, and it's a PhD that's designed for working professionals, and we're all some form of rehab professionals. So there's athletic trainers, physical therapists, there's a chiropractor, occupational therapists who already are working in the field and then are pursuing a PhD in rehab and movement science. And there are 4 different tracks. There's a performance art track. I'm on the pain science track. And so my dissertation specifically is looking at women who have pain during menstruation. And what I'm trying to do is connect the somatovisceral system. So like all of our organs in our abdominal cavity and our pelvic cavity, chest cavity also, comprise our visceral system, and connect that to the musculoskeletal system, because so many women for so long have suffered from dysmenorrhea or pain during menstruation, and we don't know enough about it yet. It's very likely that there are multiple phenotypes of dysmenorrhea, and so some people will benefit from manual physical therapy. Some people benefit more from hormonal birth control. Some people from anti-inflammatories. We don't yet know who falls into which category, so it sort of just tends to start with anti-inflammatories and hormonal birth control. If that doesn't work for you, then we go to the second line, you know. But it would be really fantastic, in my opinion, to see who falls into which category so that we can really target treatment for them so that their nervous system doesn't become sensitized and then they don't ultimately fall into this chronic pelvic pain category because their nervous system has been trained over the years to become more sensitized and send the pain signal with less and less stimulus.
This is fascinating. I feel blown away already. I think I'm a little bit speechless because I feel like that's so throughout, like, as I was kind of explaining before we started recording, the pain science world is very much like, there's no structural cause, there's no structural cause. And so therefore this is now like in your head. Or on a nicer way of putting it, they do talk about sensitization and they will say, like your body has just become conditioned to be fearful of that sensation. And it's like, but where did the sensation come from? And if I have fibromyalgia, or if I have now what you're describing, so, previously it would be like, yeah, you get hormonal birth control, or I think one other intervention. And then if that doesn't work, well, then now that's just sensitization, rather than seeing it as like, there are other things happening here that our science just hasn't yet caught on to be able to talk about in a physiological way. And so it gets chalked up to psychological.
Yes, and I think Waddell signs are a great example of that. Are you familiar with Waddell signs?
No.
So this I learned when I was in PT school is a way to, it's a series of tests that you do for people with low back pain.
Okay.
And the way that it was taught to me, the way that I learned it was you do these tests, and if they're positive, then you know that someone is malingering or exaggerating symptoms. And it wasn't until I graduated and I started studying pain science that I learned these were tests to determine who would succeed and who would not with a low back surgery. And so what they were trying to determine was these non-organic symptoms or the non-organic reasons why someone has back pain, not, and then it got twisted in the biomedical world of like, well, if it's non-organic, then it's fake, right?
That makes so much sense. Yeah.
And I think that was such an eye-opening thing for me to realize, wow, this is what I was taught in my, evidence-based Doctor of Physical Therapy program. And turns out it's one of those things that we just don't know why everyone has back pain. I think it's 85% of people with low back pain don't have an identifiable cause. So we can't see it on a scan or on an image. But that doesn't mean it's not real. That doesn't mean it's all in your head. That just means we haven't figured out a way to test for it, or, we just don't know yet. And so I think we love to simplify things and categorize them and put them into boxes so that it fits an ICD-9 diagnosis code, ICD-10.
Yeah.
And it really doesn't work well for the way that people's biology and physiology and psychology all interact.
Yeah. And it's like, I'm so glad that the science is moving in this direction. I think, as much as it's been so disastrous, I think long COVID has also brought in a lot more research for things like ME/CFS and even a little bit of like chronic Lyme, a little bit. And, even with like ME/CFS, there was a study I just read recently, really looking at some of the physiological destruction that happens on a cellular level. And now we understand things like PEM and post-exertional malaise and how that's a physiological reaction. It's actually something happening in the body that's creating and causing damage. And it's not just like you're just a little tired from working out or doing the dishes. Yeah.
Right. And that's where I feel like physiotherapy comes in. Sometimes people say to me, like, well, am I allowed to talk to people about their beliefs or their thoughts or their feelings or their social situation? And I say, we treat physiology. If these things create a physiological reaction, that is our domain. That is our scope of practice. That is where we live. And it's just, I'm hopeful, and I like that you say that the science is going this way. And I mean, it really depends on who you talk to as to whether or not you feel the science is going this way. There are some people that are saying this is woo woo, this is nonsense, this is, I think a lot of the information that came out about polyvagal theory recently kind of let people say, I knew it, I told you so, all of that's a bunch of nonsense. And, um, I'm either a neck down therapist or a neck up therapist, and never the twain shall meet. And, you know, it's just feels like an
Yeah,
uphill battle sometimes.
well, I'm thinking of what is it? There was the MECFS research that I was just looking at the other day was like really about how maybe it was about the damage that happens during PEM and at a mitochondrial level, the inflammation, the mitochondria, and that is actually I think the research that is so important. Both sides are the mental health, of course. I'm a therapist. I 100% like that is so important, and then the pain science piece of like how the way that we think about things and the fear and you and I will talk a little bit more about that can actually exacerbate pain, and even further, disability, and I'll let you kind of articulate that more, but to that point, as we're talking this entire conversation, what I think will be important to have threaded through is that there are real physiological things happening in the body that we just have not been able to test for yet. And I do think there's a lot of really promising research that's coming out about that. And I hope that it continues to gain notoriety alongside the mental kind of cognitive and somatic experiences that also deserve their research and understanding of how the two all connect.
Yeah, I completely agree. And it feels like, the top down research and the bottom up research, eventually will meet, or,
Yeah.
will kind of come to similar conclusions or working together. I feel like that's where the innovation lies, is where these two specialties kind of meet and intersect and overlap.
Yeah, exactly. Tell me a little bit about, you know, you I'm trying to think of a good starting point because I've watched so many of your snippets on Instagram, and you do a really, really good job at explaining this, like I was saying earlier, even when you're not explicitly saying this is the body part and this is the emotional or the somatic part, or you really do really just meld it together in how you talk. So I think the example I'm remembering is, you had a patient with a shoulder issue and they felt like their shoulder was fragile of some sort. He had a kind of very specific phrase he used.
Mhm. A fragile piece of plastic that's about to break.
Yeah.
That phrase
Yeah.
is
Right.
burned
And
in my brain.
yeah. And I was like, the way that you talked about it is you didn't just come at it of like, well, that's not true. So therefore let's keep moving your body. And you also didn't say like, that this was a non-issue. Your shoulder's fine. And so let's also talk about pain sensitization. Like you explained it really well. So would you like to recap where we?
Sure. Yeah. So this was a patient, and that post was really about the fact that part of what makes practicing within a biopsychosocial model challenging is the fact that it's a moving target. And so for this person, he came in 8 weeks in a sling, just a stiff shoulder, just a really stiff joint, young guy. We talked about dating in Los Angeles, I mean, just like, oh,
Yeah.
so grateful to not be in that situation. But, it was a very, pretty typical type of presentation. He's young, he's healthy, he's strong otherwise. He's just got a stiff joint. And so we worked on the body, we worked on the biology for a few weeks because this is a really stiff joint. And then he started to kind of have a plateau. And I said, this is a little bit different. I'm noticing we're not making as much progress as we were before. I'm feeling a little bit of resistance from you when I'm working on your biology. And I said, what does it look like in your mind's eye if you were to just kind of close your eyes and go into your shoulder? And he said, it looked like a fragile piece of plastic that's about to break. And part of that came from his surgeon who said, this is a very complex surgery and it was very complicated. And if you move, you're going to just mess it up. So there was a lot of fear created, rightfully so. You don't want to mess that surgery up and have to have a redo. And so he had a really, unbeknownst to me, protective posture around moving that shoulder. Once it got to a certain point where his threat detection system said, no dice, right? And he said, I am not going to go that far. And so I said, wow, well, that's really interesting to me. I didn't quite realize we were talking about this terrible date that you had been on. I thought we were, feeling good. And so we took a minute and we said, let's do some visualization. Let's address that because that's the primary issue in this moment. It's no longer primarily a biological issue. And let's start treating that and let's start working on that before we go back to the biology or before we start talking about other things.
What is the visualization that you would lead or that you did lead him into? I'm curious.
That's a great question. Let me see if I can think about that.
Because my thinking is like when we, especially as a therapist without the understanding of the ability to work with the body, right? From a lens of, I can't do PT. I can't tell someone about their muscles or what's happening or not happening. And I kind of feel like a visualization that would get somebody out of that fear response would be ineffective without that it has to be based in truth. It has to be based in what you know about the body. It can't be just, think your way out of pain. It's like, and that's where like I really dislike some of the, especially the older pain science stuff. A lot of people will bring up like Dr. John Sarno's work and like stuff like that. And it has this language of there's nothing wrong with you. This is all just learning how to force yourself to think you're safe. And that's
fake
just
it
not
till you
gonna...
make it.
Yeah.
And I really don't, I agree with you. I think that's an oversimplification. And I had someone in my comments once who was an MD who worked with Sarno and then also Alan Gordon, who I think is great. And I think that's also an oversimplification. The biomedical model is an oversimplification. Think your way out of pain is an oversimplification.
Exactly.
And I don't know if you have to know exactly the biology, but because I also teach pathology, I talked about tissue healing times. We know that soft tissue heals in 6 to 8 weeks. We know that bone heals in 8 to 10 weeks. At this point, he was 12 weeks out from surgery. And so I know that that bone has grown around that. And so we talked about how that happens and bone has the ability to remodel better than any other type of tissue in our body. If any of my students are listening to this, that might be on your midterm next week. And so, we talk about how that is most likely the truth. And then let's think about what your most recent x-ray looked like. And we can even bring that in as a visual. And so sometimes I'll talk about the specific biology and that's great for some people. This kid actually happened to be in the medical field. And so he really liked to talk about things like that. But for some people, we're just talking about, it looks really red and hot in there. And so are there things that you can do visually to think of cooling it down and getting it to more of a blue color? Or is it expanding out and really throbbing? Can you get some kind of a visualization of allowing that blood flow to move through there? Things like that, that it doesn't need to be super, super specific for everyone. But I do think that having that kind of physiology, biology background can be helpful for some patients.
Right. I mean, inflammation, I think that obviously inflammation and redness is something that even the majority of, non-science people know. So that's kind of an easy one. But even still, I could imagine if I knew nothing about the body, being a little bit scared as a therapist to go there and to be like, or to say something wrong if I don't know what the underlying biological thing is that's happening. So like whether that's inflammation or, maybe their tissue is, maybe this is like 2 or 3 weeks in and it's, it is a little bit uh, more fragile at that time and hasn't gotten better quite yet. So I think that's where our work just is. It's funny because like Jason, he's been on this podcast a few times and he's speaking at the conference. He's a PT and he kind of, he loves the work that we do as therapists, like the mental health side of things. And I'm like, I think it's just because you know so much about your work, you're maybe bored with it or something because it feels like common knowledge to you, or it feels like
Right.
this is your base level of understanding. But for someone in a different field or just, or a patient who's not in the field at all, like that's can be really life-changing in addition to all the other stuff that we're working on.
Yeah, definitely. I mean, we're all so biased to our own knowledge base that it's kind of hard to think like, wait, what do other people know versus what do I know? It's kind of
Wow.
like, where
Yeah.
am I on the spectrum here?
Yeah.
Excuse me. And I think
Definitely.
a lot of our research in physical therapy for a while went to explaining pain. And this was kind of like, oh my gosh, we have been missing this huge piece for so long. And we've been explaining the biology to people this whole time. Whoops, like what a big
Yeah.
misstep. And I talk about this in my classes, Explain Pain from Lorimer Moseley has been around in 2015, he wrote, 20 years on of explaining pain. And at that point, prevalence was 20% of the population had chronic pain. Then pain prevalence is 20% of the population now. So it wasn't really this panacea that we thought it would be.
Yeah.
And then a lot of research came out that said, well, actually, pain neuroscience education needs to be part of your treatment plan. And there was some interesting research that came out that showed actually, even still, if you are explaining the biology and physiology to patients, they have a very similar outcome compared to when you're explaining pain to them. And the underlying thought there was it's the relationship. It's the fact that you took the time to communicate to me what was going on. I trust you. My threat detection system has come down. And what do you know? My outcomes are better.
Exactly. There's I used to see a particular practitioner and it's been a long time since I've done anything like that, but they used to take your heart rate, your HRV when you came in and then
Mm,
do a for your baseline, but then retake it in 12 weeks. But I think it was interesting. Like if I've been seeing you for 12 weeks and we've built a relationship, we do know that trust feels safe and safety brings your heart rate variability a little bit more um, even. And so
mm,
I'm like, we still don't know. Like, was it this 12 weeks of this clinician doing something physically to me, or was it just this relationship that we've built and I feel safe coming here and I like coming here? And
right,
yeah,
right. Which is one of the reasons why it's so difficult to do research in physical therapy, do research in manual therapy. I'm using a heart rate variability test for my study, but it's really difficult to come to any kind of conclusion about it, short term or long term, because we just don't know enough yet. We haven't established norms, and there are a lot of unknowns. But I think I mean, we don't have a better way to study someone's nervous system. So I
yeah,
think this is this
yeah.
seems like the best option at this point, and if we just continue to learn more about it, I think over the next few years, maybe decade, we'll get a lot better information.
Yeah. Yeah, I agree. I think we will because like I was saying, I think our research just continues to keep expanding despite, our administration's every effort to make that not happen. But um, regardless, again, I'm very hopeful about a lot of the research, the physiological side of things that's coming out. Um, and also like, yeah, I know HRV it's not the end all be all, but it's a really useful tool. And their HRV is improving while working with you through a specific, time frame, then I mean, at the end of the day, and this I think comes down to some of the work that I do on that kind of lifestyle management piece is how do we kind of live a life that is meaningful and joyful and uh, is the life that you want to live, even if you're still in pain. And that, so I think, and that in and of itself is going to help that HRV if we know that trust and being communal and improves your HRV, then it all that's how it, like you said, it is a moving target on what we're targeting, but it also always works together. So it's almost like moving target, but still within the same bullseye. Like it's within the same circle. It's not 10 different circles that you're jumping out of, which I think is maybe how it can feel when you're first learning this stuff.
Yes.
But the more and more you do this, to me, that's the visualization that I have is like one circle. And yeah, it's moving around in this one circle, but it's not, all over the place.
Yeah, I kind of visualize it as three pieces of a pie, like a pie chart, the bio, psycho, and the social. And what is the
Yeah.
biggest piece today? What are you coming in and talking to me about? Because students do, they come in and they say, so everything affects everything, affects everything. Where do I
Yes.
start? How do I approach this? And it can be very overwhelming, and it is very difficult to teach people how to treat someone in chronic pain because it's never the same. I can't give you a formula. I can't give you an if this, then that type of chart that you go through. The answer is always it depends, which in physical therapy school, luckily, we're used to hearing that quite frequently.
Yeah, that's too.
And so it helps, but it is a lot. It's a lot to
Yeah.
be thinking about. It's a lot to be tracking. It's a lot to be understanding.
Well,
I think my goal for my profession is that we start to take a step back and recognize that this person's been in pain for 10 years. Their tissue has healed at this point. If it's not somebody that's chronically aggravating something, if it's not an acute
yeah.
on chronic exacerbation, then we need to be looking at different pieces of the pie. I think it's really hard for new clinicians, especially to say, okay, someone has had pain for 10 years. It's, that the falling hands, where's the pain? Everywhere, right? Where do I even start? How do I even start to piece this puzzle together? And it's very challenging for me. I tell them that I don't have a 100% success rate, and these cases are challenging and they do require a multidisciplinary approach. And so it is great to be able to talk to other types of providers and, especially when you're talking about the social piece and that connection and my lived experience with this condition, because that as physical therapists is definitely a piece that we don't often address, don't often feel comfortable addressing, uh, haven't had enough education in most cases to address. So it's really great to be able to partner with someone that you say, okay, they're primarily managing this piece of the
Yeah.
pie, and at least we know that's covered, and I'm going to check in on it, but it's not my whole
Yeah.
to hold.
Yeah. I do think that's probably the piece where people get really scared about whether it's a therapist trying to do any kind of breath work or body based work in session, or a physical therapist trying to do some of the mental load of, the psychosocial part of it. It does really, really help when you know that your client or your patient is working with another practitioner, because you're like, I can say this one snippet, and if it lands with you, great. And then you take that back and you continue working on it with the person who can spend the hour with you on that one thing. Um,
Yes.
yeah.
Yeah, definitely. It's interesting. When I first graduated from PT school, I was very orthopedic based because I spent the better part of 9 years studying anatomy and physiology and biology. And, you have a certain level of success rate. Typically in physical therapy, you're at about 70% success rate when you treat biomedical model, which is, a good average, 70%.
Yeah.
But, there are those of us that are a little more type A that are like, but, what do you mean?
Yeah.
Serious.
Yeah.
And so that's when I started pursuing other types of manual treatment. And I went to 2 years of um, osteopathic coursework in the somatovisceral system because, we're taught that we're operating under a connected system. And you're telling me that on the anterior side from collarbone to pubic symphysis, that's not part of this connected system.
Great.
And, physical therapy school, really, we get about a week about somatovisceral system in PT school and cadaver lab. So it's not a lot. And I started to have a little bit more of a success rate with people who maybe had a somatovisceral component to their musculoskeletal presentation. And so then I think, okay, great. I'm having a little bit more success. Things are going in the right direction. And then there's still that percentage that are not getting better. And so you're saying, what else is going on? What else is out there? And I was lucky enough to have a mentor from physical therapy school who treated my chronic pain when I was in PT school. I had a fracture of my lower leg when I was a senior in undergrad. And I had a metal rod that was put inside my bone in the bone marrow area and some screws. And I had knee pain for 6 years after that. I couldn't run. There were certain things I just couldn't stand for long periods of time. And I went to probably 4 or 5 physical therapists, and I got pretty much the same thing from all of them until I went and saw this person who asked me very different questions, asked me a lot about what I had done previously, and said, great, that's great news. We don't have to kind of go down those roads again. And that's when I said, I want to find out what this guy is doing. I need to get a little bit more information about this. And so I made it a point to get one of my rotations at his clinic before I graduated. And I just had to figure out what he was doing and how he was doing it differently. And he happened to be in his PhD program at the time and was learning more about pain science and has continued to study and research and publish about pain science. And yeah, that's kind of how I then started to shift my practice and my understanding and my knowledge. And what's interesting is when I was really into the somatovisceral work, I got a lot of referrals from, gynecologists and gastroenterologists and urologists and, doctors who treat somatovisceral issues. And now that I'm more of a pain science physical therapist, I guess you could say, which there really isn't a pain specialty in our field yet, most of my referrals come from talk therapists.
Yeah. We do like to know when a medical professional can, like a body-based professional is not scared of talking about the emotional, because even though we were just talking about, working collaboratively with one another, so you don't have to do a whole therapy session with these clients. If I'm working on something from a mental, emotional standpoint, and then you go into your PT and they're like, this is just blah, 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 blah. You just need to do your exercises. Okay. And then we're going to be good. And I need to know that that's not the experience because that my client's going to get, because then you're going to really undo a lot of our work.
Right. Yes. And that's a really hard thing, even like I say, within our profession. I worked at a group practice where I had somebody that had 10 years of pain. It was a work comp injury. I really was kind of going down this pain science route with her, and she ended up on someone else's schedule one day, and he did a complete re-eval on her that was very biomedical. And I feel it completely undid so much of the work that we had done.
Yeah.
And yeah, it is still a problem in our profession. I'm sure, like your profession, there are different schools of thought that are sometimes contradictory, and
Hmm.
it becomes very challenging.
It does. It does. How do you start to differentiate? Like, we did kind of talk a little bit about, okay, if somebody's been injured for 10 years and we do know the tissue has healed, but how do you also maybe rule out or differentiate between, chronic inflammation that is causing the pain or like, um, for example, we now know that this is something I have a lot of clients struggling with it now that we never used to check for, like pelvic congestion, the venous congestion in your pelvis. And that can be for some people very painful. Um, and so these are conditions where, again, like no one would have checked that. So it might have been 10 years with nothing wrong, but structurally, but maybe there is. And so people will talk about, well, you have to do a proper medical exam, but we're also lacking a lot in the proper quote. If you go do a physical with that's not a physical at your PCP. That's not what we're talking about here. I mean, how do you start to differentiate some of that?
Yeah, and I think that is part of the challenge. I think a big starting point for me is a thorough subjective exam.
Okay.
And I'm lucky in the situation that I am in where I am one on one with people for an hour. A lot of times for the initial evaluation, I book 90 minutes because I really want to know all of it, like the whole
Yeah.
story, how this began, what has happened, throughout. Sometimes people cringe when they see somebody coming in with a 3-ring binder of their medical history. And I'm just like,
Yeah.
thank you. It's in there's files, there are tabs. I love it. Um,
Yeah.
so I think it has to start with a very thorough subjective exam. And then I get a lot of information when I put my hands on someone. You can feel like a boggy joint. We're taught how to feel like end feels, and we're taught how to feel like normal ligament laxity versus abnormal, kind of like you were saying in a hypermobile individual. And so my manual is a huge part of my physical therapy treatment, which unfortunately a lot of physical therapists, believe it or not, are getting away from. And part of the reason that's happening is because the research has really shifted more towards motor control, biomechanics, strength training, neuromuscular reeducation, all of those types of things. But my reasoning for, and so, then they say, well, manual therapy just doesn't really do anything, right? You're not breaking up scar tissue, you're not elongating muscles, you're not, you know, whatever people were claiming to do previously with manual therapy. And I say, that's not why I'm doing manual therapy. I'm
Yeah.
doing manual therapy sometimes to create a trust relationship with my patient.
Yeah.
I'm doing manual therapy to help their nervous system get into a better state so that healing can happen. And I'm doing,
Exactly.
yeah, and I'm doing manual therapy to help decrease some of this protective mechanism that's going on in their body so that
Yeah.
they can move in a way that a motor control person wants them to move, this ideal
Yeah.
movement pattern. I
That's
think
right.
in physical therapy, we just kind of, like you say, sometimes boil it down to like, well, you just need to move better. Well, you just need to get stronger. Well, you just need to stretch. You just need to strengthen. And my thought is, if it was just that, they would have done that already.
Exactly.
And so, what
Yes.
is it about their system that's not allowing that movement? And I
Yeah.
think what I'm asking myself is, what's the fear here? Where is this person detecting a threat so that they're not doing that movement, or they're not activating that muscle, or they're not stabilizing in a way that you would expect?
Yeah. Yeah. I mean, my brain does tend to go back into the bio of it all because And maybe that's just when you live with chronic pain, you do tend to want a biological reason.
Mhm.
And so I will admit I do still go there because even as you were saying, like, you know, as someone, I'm thinking when my own PT often starts at my neck and gets some knots out of my neck, like, and I do feel my nervous system relax. Like I might come in a little bit on high alert. I might come in a little bit shaky, almost like I had coffee, even though I don't drink coffee anymore. And as soon as that happens, again, maybe it was just the trust of somebody putting their hands on me. Maybe it was the
Mhm.
knots that were actually, they're there when I walk in and they're not there when I walk out.
Mhm.
So I just think, what do we need? Do we need more physiological understanding of what's happening there for science to be like, this is legit, that this is doing something? I just think there's always a physiological, even if it's reducing stress through trust, there has to be some kind of chemical cascade, the higher oxytocin or something like that. Tell me if I'm off base on any of that.
Yeah, no, you're absolutely right. And they've even done studies where they give people a pain stimulus while they're in an MRI and they see, things light up, somatosensory lights up and all of that, and they report their pain at a certain level. And then they have someone stand next to them, even if it's someone they don't know, even if it's someone they don't have a relationship with, they give them that pain stimulus and they report it as lower. So that is a part of it. And sometimes I tell people that pain is a learned response, which can be a hard thing to say to someone. And I really talk about the type of learning when I give that explanation. And I say, I'm talking about associative learning. I'm talking about the learning that happens when Pavlov rang the bell and gave the dogs the food. And so they learned that that bell meant food. And you
Yeah.
learned that moving in that certain way meant danger.
Yeah.
Uh, that maybe was 20 years ago. That was maybe 30 years ago. Maybe you don't remember that.
Yeah.
But there was a physiological component to this at one point. Maybe that's not the driver currently, but you also learn this physical therapist is safe. They make me feel good. I have an expectation that I'm going to have some good
Yeah.
zhuzhi work on my
Yeah.
neck.
Yeah.
And so all of that gets into our nervous system and we take that with us and we say, oh, I know this is going to feel great. I'm going to walk out of here without knots and I'll feel good for, whatever that period of time is.
Yeah. Yeah, I get that. And I think there's the learned component mixed with just the component of feeling safer when someone's next to you, or, you know, that inherently just simply does something physiological to you. But the physiology of it wouldn't be enough though, to like sustain a calm state, or to, that's where I think the belief system can come in. Like, but beliefs are formed not from I decided to believe this today. Beliefs are
Mm-hmm.
also a learned behavior. They're also something that is ingrained in you time after time after time, a lot of
Right.
times unconscious and of no fault of anyone's. It's just the society you live in will form and shape your beliefs. So I am a big fan of uncovering kind of maladaptive beliefs, just as long as we are not using that in the way of like, again, oh well, your labs are fine, so you just have this belief now that you're in
Right.
danger and you're not in danger. And it's like,
Right.
that doesn't feel helpful when, again, it takes a very long time to get proper diagnoses. And there could be something structural or just like, again, inflammation, or I'm thinking of like the pelvic congestion kind of syndromes, things like that just
Mm-hmm.
are physical, that are just not going to be caught on our average tests.
Right. I mean, I feel like just believe differently is the mental health equivalent of just move differently.
Yeah,
It's
exactly.
just like, if I could, I would. I would love
Yeah.
that. And,
Yes.
I've been presented with enough evidence that shaped my belief system,
Yeah.
like you say, that I've learned that this equals that. And so I'm not just going to overnight decide, like, you know what, you're right.
Right.
Like,
Yeah.
I'm going to change my whole belief system. Thank you so much. If only someone had just said that to me.
Exactly. Yeah. We really need that repetition and also to trust the information we're being told, which is why I think that relationship is so important too. Um,
Yes. And I also feel like the subconscious mind needs proof.
yes.
Like, if you tell me something and my experience is the complete opposite, I just I can't grab onto that. I can't integrate that into my nervous system.
Yeah.
But if you tell me that, I see it, I feel it. So now I have some proof in the opposite direction.
Yep.
I think that's when really people can kind of grab hold and I say kind of grab that rung of the ladder and start to pull yourself
Yeah.
out.
Yeah. Yeah. And for some of us, from my own training as a therapist, I think what I bring to the table in this conversation is that deeper understanding of personality types and the difference that, somebody might need, like my husband, he needs information once. He
Mm-hmm.
just needs to hear it once. And like, if it makes sense, he's good. And of course, makes sense. We all have a different way in which we make sense of the world. So,
Sure.
in what he trusts and believes, that the sources of information that he believes and trusts in, he needs to hear it once. Even when I believe and trust in something, I still need to hear it several times before it really feels ingrained.
Mm-hmm.
Um,
Mm-hmm.
and so in therapy and in physical therapy too, I think it's really important that we recognize that as legitimate, right? That there's just simply different personality types, different brain types, different ways of learning. We understand some people, learn better through hearing, and some people learn better through writing, and some people, learn better in different ways. But I think we somehow have missed the mark when it comes to some people need more repetition than others. Like we think that person is, just being stubborn, or they're being dramatic, or whatever it is, rather than just seeing it as this kind of learning difference in your brain.
Definitely. And I talk to my students, we do an exercise where they teach pain science to different types of patients. So you teach it to an 8-year-old, you teach it to a 40-year-old computer programmer, you teach it to a physician, an 80-year-old woman, someone with English as a second language. And so that's a really good point that we think about the different types of education that those people might need, but we don't necessarily always think about the different um, personality types within we're really kind of
Yeah.
categorizing, well, you're a 40-year-old computer programmer, you like a lot of detail, right? So
Right.
not always the case, but
Yeah.
you can kind of make some generalizations. But yeah, that's a really good point that I might have to think about how I can design an
Yeah.
exercise around that.
Definitely. Yeah. Yeah. And also it brings me a little, also hope to think about, especially as so many of us are going into private practice. I think sometimes I'm not sure how it is in your field. Sometimes in my field, it can feel very competitive, and I hate competition. Like, I'm not a competitive person at all. When I feel it, it like makes me shrink. But, so I try to push that far away. But if you think back to, before technology really, we used to only know like around 150 people from the day we were born until the day we died.
Is that
And
right?
so,
Wow.
yeah, now like you could hear 150 different opinions literally in an hour on TikTok if you're just scrolling fast enough.
Absolutely. Yeah.
And so it makes me think that, these private practices, like we don't need to have these huge competitions of, how many patients can you work with, or how much. It's like, we need these kind of small little villages where like 10 of us in this one town might, I live in a big city, but, there might be, there's room for dozens of us in this city to all know this information and to all be the best for our patients. We don't need to be seeing 150 people, a week. We need to be seeing a few, or yeah, it's not a fully fleshed out kind of opinion, but It's something I've been thinking about. Like, when you can focus on these small groups, then I think you can be of so much better service because you get to know them and their personality, and like, rather than just this kind of, what does the textbook say? And then let me help as many people with what this textbook says. Yeah.
Yeah, I think about that a lot. I had to take an ethics class as part of my PhD program, and I think about it as kind of like the difference between like utilitarianism versus like a feminine ethics kind of a model where
Yeah.
um, you help the people that are in your circle and you do it as well as you possibly can. And if everyone does that, then everyone's covered versus let's give everybody 15 minutes of pain science education and throw it at the wall, see what sticks. Yeah, I mean, physical therapy is personal, and just like talk therapy is so incredibly personal, and that relationship is such a large component of will someone get better or not.
Yeah.
And that's why my husband and I created a listing service for physical
Yeah.
therapists. Shameless plug here, by the way.
Yeah. Please talk about it. Yeah.
We're calling it like the Psychology Today for physical
Yeah.
therapists because there really wasn't something like that
Yeah.
for like there's the APTA has, a listing service, but it, a lot of these solopreneurs who have these very niche practices that are kind of one off on their own aren't APTA members because they don't really see a lot of benefit out of paying $600 a year for
Right.
something I'm, kind of out of the system. But I
Yeah.
think having that community, having the ability to say, I specialize in this, and these are the types of people that would benefit the most from me is not only great for a patient to be able to find, but a practitioner to be able to say, I'm really not the best person for you, which I know is hard for all of us,
Very hard,
but
but important.
and important. Yes, absolutely. But I'm on this listing service and I see this person that's not that far from you, and it seems like they might be a better fit. And,
Yeah.
you know, yeah, I think that's really
Absolutely.
ideally where I'd like to see our profession going. It seems like we're going very much more towards the private practice. I mean, we've been fighting this reimbursement from insurance for so long, and it just continues to be a losing battle. And I know
Yeah.
so many other practitioners and all of healthcare are feeling very similarly. That it's just
I
so
know.
hard.
We have it bad as well, but you guys, I think, take the cake. Like, insurance, like,
It's
really, really bad for PT.
really bad.
Yeah, it's very insulting.
It is. And I think for a long time, physical therapy thought, well, if we can just prove it, if we can demonstrate
Yeah.
in the literature that we're as good or better than surgery, and
Yeah.
we've done that over the last
Yeah.
15 years, maybe even 20 years. There have been
Yep.
so much research that comes out that shows the efficacy and the cost savings
Yeah.
and the outcomes. And yet the insurance says, that's nice. Can't help you.
It's gotta be
$47 a
lucky.
visit.
Yeah. Yeah. I've heard even lower, like 32, crazy for
Mhm.
an hour-long visit.
Mhm.
Like,
Not
I
sustainable.
um, I would imagine whoever builds the machinery for surgeries probably has a stake in the lobbying for reimbursement rates.
I wouldn't doubt it. I would not doubt it. Yeah, I
And
mean,
then,
seeing these insurance companies testify before Congress, I was just disgusted,
it's awful.
it is awful. So I think there are some reforms coming because honestly, this is just such an unsustainable
Yeah.
model that we're all living in. I mean, from every aspect of healthcare, there are people that are just burning out at record rates.
Yeah.
And so I think they've got to do something in order for
Right.
this to be sustainable.
Yep. Anything else feels important to you before we end today? Is there anything we haven't covered that, you want people to know?
might just want to say another thing about manual therapy.
Yeah.
So I think another reason that I use manual therapy in my practice is that a lot of the research is showing us that as pain chronifies or becomes more chronic, the, it goes deeper into our brains, right? And so it's less about the somatosensory, my cognitive thinking brain, and more into my reflexive, reactive, self-protective preservation brain.
Yeah.
And that's really difficult to access through education, through talking. And so if I knew how to hypnotize people, I would do that. I understand that's a great way to get into someone's subconscious.
Yeah.
But I also use manual therapy to do that. So there are
Yeah.
types of manual therapy that you can use that help talk to someone's subconscious so that some of that reflexive, protective mechanism is lowered. And like you say, some of that manual therapy lasts for a short period. But if I can get your protective mechanism to come down a bit, then you're much more likely to try movement. You're much more likely to try an exercise
Exactly.
and have success.
Yes. That's been my experience 100%. Because I know that if I hurt something or if I, whatever, that I can, like, I'm going to go to PT, and whether it's in my head or it's actually something physical, either way, I'm going to walk out of there feeling better, which allows me to then go try that movement.
Yeah. Wonderful.
Yeah. Well, thank you so much. I'm so glad to know that you're teaching this stuff to other PTs. Yes, because it is really, we went from like biomechanic to pain science, forget about the body kind of thing. Like, and we need both so importantly. We don't want to throw the baby out with the bathwater. That doesn't help anybody. And
Absolutely.
I just get that from your content whenever I watch it. So I'm so glad that you're doing this.
Oh, wonderful. Thank you. Some people are getting the throw the baby out with the bathwater, and they get really mad at me in the comment section. So I'm glad that someone is not. That is
I
not
think
always the case.
no, it's not. It's not at all. And, Instagram is 30 to 90 seconds, and people need to listen to more than one thing to really feel like they can have an opinion about what somebody thinks or doesn't think. So
Absolutely. And that's why I'm so grateful to you. I mean, to have this long form content is to be able to kind of like expand on these topics. And I think that's a really important thing for patients and clinicians to hear as well. So thank you so much for having me.
Yeah, absolutely. Well, thank you.
Thanks for listening. If you learned something new today, consider writing it down in your phone notes or journal and make that new neural pathway light up. Better yet, I'd love to hear from you. Send me a DM on Instagram, email me, or leave a voice memo for us to play on the next show. The way you summarize your takeaways can be the perfect little soundbite that someone else might need. And lastly, leaving a review really helps others find this podcast, so please do if you found this episode helpful. And P.S., clicking subscribe ensures you'll be here for the next episode. See you then.